everyone. Welcome to our annual Baby Checker webinar. Our theme today is Leapfrogging Maternal Health Challenges, AI-enabled innovation for equitable health access in low and middle-income countries. My name is Kaatia, and I'm delighted to host you today. Today, my colleagues and I will be joined by experts from Zambia, Kenya, and Sierra Leone to discuss how AI-enabled solutions can strengthen maternal and antenatal healthcare in low-resource settings. Our speakers will talk about the challenges they face on the ground and how AI solutions like Baby Checker can and are moving beyond immediate fixes and playing a role in sustainable
हम देखेंगे कि AI कितना ज़्यादा बेहतर किरदार अदा कर सकती है हमारे ऐसे ममालिक में जहाँ पे कम वसाइल हैं, वहाँ पे बच्चे और माँ की सेहत को बेहतर बनाने के लिए क्या किरदार अदा कर सकते हैं। इससे पहले कि हम वेबिनार को शुरू करें, मैं आपको बताते चलूं कि हमारा ये वेबिनार का तर्जमा हो रहा है फ्रेंच में, स्पेनिश और उर्दू में। तो आप देखें कि आपने सही चैनल चुना है कि आपको जो आवाज़ आप सुनना चाहते हैं वो आवाज़ आए। आप अपने सवालात को प्रेजेंटेशन के दौरान क्वेश्चन एंड आंसर सेशन में डाल सकते हैं और हमारे पैनलिस्ट, हमारे कोलीग इसमें डालेंगे। तो सबसे पहले मैं अपने सबसे पहले स्पीकर को मुतारिफ करवाती हूँ। मेरे मैनेजिंग डायरेक्टर हैं फलूरेंट गैरट्स, जो हमें इस बारे में बताएंगे कि हम मुसावी सेहत के थैंक यू कहातिया, आपका बहुत शुक्रिया कि आपने मेरा तारफ़ कराया। आप सबको बहुत ज़्यादा खुश आमदीद है। इससे पहले कि मैं अपने ड्राफ्ट इमेजिंग अपनी ऑर्गेनाइजेशन का आपको तारफ़ करवाऊँ, मैं आपको बताऊंगा कि हम बेबी चेकर के बारे में बात करेंगे। अगली स्लाइड दें। थैंक यू।
Perfect. One more. So to give you a little bit of a background of where we come from as an organization.
हम पहले इसके पहले बैकग्राउंड के बारे में बात करते हैं, जो पहले से जो लोग नहीं जानते, ताकि उनको भी पता चल जाए। 20वीं सदी के शुरू में जिस तरह हमने ये इमेजिंग का काम शुरू किया, ख़ास तौर पे स्क्रीनिंग के मामले में, उसके बारे में बात करेंगे कि जो बेहतर किस्म के एनालॉग एक्सरे और चल के जाने वाले क्लिनिक्स के बारे में बात करेंगे। साल हर साल से जैसे जैसे टेक्नोलॉजी बेहतर बनती गई डिजिटल एक्सरे की तरफ और आर्टिफिशियल इंटेलिजेंस का किरदार बढ़ता गया, तो हमने इसको अपने इसमें शामिल करना शुरू किया। स्क्रीन को टीबी से शुरू किया कि जो 70s की दहाई में बहुत ज़्यादा खतरनाक थी, और इसकी टेस्टिंग के बारे में बात की। और फिर इसको वक्त के साथ साथ यूरोप के बहुत सारे ममालिक में गए जहाँ पे टीबी बहुत बड़ा मसला था, आज भी बहुत बड़ा मसला है। तो कम वसाइल वाले ममालिक में तो ये पहले से बहुत ज़्यादा मसला था, जिसकी वजह से टीबी के बारे में बात की जाती थी। उसके बाद हम फिर टीबी से लेकर बेबी चेकर की तरफ बढ़ना शुरू हो गए। ये हमारी तरफ से ये बहुत ज़रूरी है कि आप नोट करें कि डेलफट इमेजिंग एक सोशल अदारा है, जो कि एक प्राइवेट ऑर्गेनाइजेशन है। जो हमारा बहुत ज़्यादा फोकस है ऐसे ममालिक में जहाँ पे वसाइल कम हैं और जहाँ पे माँ की सेहत के लिए वसाइल बेकार नहीं लाए जा सकते, और बाकी भी हेल्थ केयर के लिए बहुत सारे मसाइल हैं। तो हम और बहुत सारी लाखों जिंदगियां बचाई जा सकती हैं। हमारा ये पूरी दुनिया में काम करके हम लाखों जिंदगियां बचाने के लिए काविश कर रहे हैं। साल हर साल से ये चीज़ चलती जा रही है, जो कि यूनाइटेड नेशन में शामिल ममालिक से की जा सकती है। कुछ ऐसी चीज़ें भी हैं जैसे हमारे इसमें हमारी ऑर्गेनाइजेशन में जो साल हर साल से बहुत ज़्यादा बाअसर रही हैं, जिनमें सबसे ज़्यादा बेबी चेकर की सहूलत है। आज के इस वक्त में हम आपको बताएं कि हमारी टीबी के साथ साथ बेबी चेकर को भी शामिल किया गया है, तो इसके 85 से ज़्यादा ममालिक में शामिल हैं। हम देख सकते हैं कि ये اور کہ یہ سارے وہ ممالک ہیں جہاں پہ بہت کم وسائل ہیں صحت کے لیے، جن کو ہم کم وسائل والے ممالک کہتے ہیں۔ وہاں پہ پریگنینسی رسک کے بارے میں سہولیات میسر نہیں ہیں۔ جہاں پہ یہ جو اورنج کلر ہے یہ وہ ممالک کو بتا رہا ہے جہاں پہ ہمارے ہیڈکوارٹرز ہیں نیدرلینڈ میں، جو یہ کام کر رہے ہیں، گانا میں، نائجیریا میں، انڈونیشیا میں۔ ہمارے ہیڈ کوارٹرز نیدرلینڈ میں بھی ہیں اور یو ایس میں بھی ہیں، کیونکہ ہم صحت کے مسائل کو لے کر پوری دنیا میں کام کر رہے ہیں، ساؤتھ میں بھی۔ ہر سال 40-30 لاکھ سے زیادہ لوگ ہمارے پرپوز کیے گئے امیجنگ کے طریقہ کار کو استعمال کر رہے ہیں، اور الٹرا ساؤنڈ کو اور ایکس رے کو۔ ایک اور چیز جو میں بتانا چاہوں گا بیبی چیکر کی طرف جانے سے پہلے، تاکہ آپ کو بہتر طریقے سے آپ کو بنیادی سمجھ آ جائے کہ ہم کس طرح بات کرنا چاہتے ہیں، وہ یہ ہے کہ ہم نے صحت کے سہولتوں کو، مسائل کو سامنے رکھ کے بہت زیادہ کام کرنا شروع کیا، جو کہ ایکس ریز پہ تھا، ڈیجیٹل ایکس ریز کی طرف تھا، اور ایسے کلینک جو ٹی بی اسکریننگ کر سکیں، اور موبائل کلینک جو چل کے ایک جگہ سے دوسری جگہ جا سکیں۔ جیسا کہ ایک کیڈ سافٹ ویئر کے ذریعے ہم نے ٹی بی کو استعمال کرنا اور بیبی چیکر کو استعمال کرنے کے لیے اور ہارڈ ویئر اور سافٹ ویئر دونوں کو ملا کے جتنے بھی مسائل تھے ان کے حل کے لیے کام کرتے ہوئے ہم نے یہ چیزیں ایسی چیزیں بنائی جو سسٹین کر سکتی ہیں۔ اگلی سلائڈ دیں۔ اے آئی کے بارے میں بات کرتے ہوئے میں ضرور آپ کو بتانا چاہوں گا کہ اے آئی کے طریقے سے جو ہم نے ڈیٹیکشن، پریگنینسی کو ڈیٹیکٹ کرنے کا طریقہ کار اختیار کیا، جس میں ٹی بی کے بارے میں معلومات حاصل کرنا بھی شامل ہے، اور ڈیجیٹل ایکس رے سے پریگنینسی کے بارے میں بھی معلومات لینے کے پریگنینسی میں کون سے رسک ہو سکتے ہیں، کون سے خطرات اس میں شامل ہیں۔ ہم نے اپنے ایکس ریز کو اے آئی کے ساتھ ملا کے ایک سسٹم، ایسا سسٹم متعارف کروایا ہے جو 400 ایکس رے لینے کے قابل ہے، اور یہ ایک جگہ سے اٹھا کے دوسری جگہ بھی لے جایا جا سکتا ہے، اور اس کا صرف 30 کلو وزن ہے۔ تو آپ یہ 4x4 کی ایک ایون بورڈ ہے جو اس کے لیے چاہیے۔ یہ ہارڈ ویئر بڑی آسانی سے ایک جگہ سے دوسری جگہ لے جایا جا سکتا ہے، جو کہ کیڈ سائڈ ہے، جو سپورٹ کرتا ہے عام بہت معمولی قسم کے پڑھنے والوں کو بھی، اور ایک جگہ سے دوسری جگہ آرام سے لے جایا جا سکتا ہے۔ یہ ایک بہت ہی اہم چیز میں آپ کو متعارف کروانا چاہتا ہوں، جو ہم ٹی بی کے بارے میں ہم نے ٹی بی کے بارے میں اس کو متعارف کیا۔ یہ کیڈ 3B سافٹ ویئر ہے، جو کہ 1996 میں اس کو ہم متعارف کروایا گیا ٹی بی کی اسکریننگ کے لیے، جسے ہم ٹی بی کو، جبکہ ٹی بی بہت بڑا مسئلہ تھا، تو یہ 20 سال پہلے جب ہم نے یہ شروع کیا 2007 میں، تو ہم نے اس کی سرٹیفکیشن لی 2015 میں، اور 2018 میں ہم اس کے بارے میں اسکریننگ کرنا شروع، لاکھوں لوگ اس سے اسکریننگ سے فائدہ حاصل کرنا شروع کر چکے تھے، خاص طور پہ ٹی بی کے بارے میں۔ پھر 2021 میں، کیونکہ اس کی ویلیڈیشن ہونا ضروری تھی کہ پروجیکٹس میں چلنا تھا اس کو، تو اس نے ورلڈ ہیلتھ آرگنائزیشن کو نے بھی اس کو انڈورس کیا، اس کی تعریف کی، اور ٹی بی اسکریننگ میں اس کی اہمیت کو جانا۔ اور آج یہ بہت سی بہترین الگورتھم والے جتنے بھی آلہ جات میسر ہیں، ان میں 85 ممالک میں جن سے اسکریننگ ہو رہی ہے، 3 کروڑ لوگوں کی اسکریننگ ہو رہی ہے، اور یہ 100 ایپلیکیشنز کے ذریعے ہو رہی ہے۔ میں یہ ہائی لائٹ ضرور کرنا، ہائی لائٹ سمجھتا ہوں اسپیسیفکلی کہ ہم نے اس کو بہت سارے ممالک نے اس کو اپنی نیوز ہیڈ لائنز میں شامل کیا، جیسے کہ بنگلہ دیش میں، سیریا میں، گھانا میں اور ازبکستان میں. تو ہم یہ سارا کچھ، یہ وہ مثال ہیں پوری دنیا میں کہ ہم نے اسی طرح کی ٹریجیکٹری سے پہ کام کیا.
quite rapidly across the world and really having a real life clinical impact in those areas where it's needed the most. Next slide, please. One of the things I also briefly wanted to mention is that we're doing a lot of
ایک اور جو
research
میں
currently
مختصر چیز
also
آپ کو
using
بتانا چاہ رہا ہوں
and
کہ
AI
ہم ایک
for
ایسا
heart
الٹرا
monitoring,
ساؤنڈ
and it's
کا
actually something that we build upon the
پھیپڑوں
experience
کا
that we
الٹرا
have
ساؤنڈ
with the
متعارف
baby
کروایا ہے
checker
اے آئی کے
using both
ذریعے،
the handheld
جسے
ultrasound
ہم
and on top of that
پھیپڑوں کے
AI
بارے کی
to
جانچ
control
اور
the sweeps that people have to make,
بیبی چیکر
and
بھی
then working with
ہینڈ ہیلڈ بیبی چیکر ہے جو
artificial
ہاتھ سے
intelligence
پکڑ
to
کے
basically identify potential abnormalities.
الٹرا ساؤنڈ کر
So this
سکتا
is
ہے، جو
actually a
کہ
new area of research after baby
تشخیص کی
checker
جا
that
سکتی ہے کہ
managers
کوئی
have
ایسا
experienced and is
مسئلہ
used
جو
in
پریگننسی
ڈیلفٹ,
کے دوران بچے کو
that
جو
we're
وہاں
actually
کو
now
ہو
doing a
سکتا ہے،
lot of
اس
research
کی
in and that we think
بہتر
will use
طریقے سے
technology
تشخیص کی
towards
جا
the
سکتی ہے.
future. Next slide, please. Yeah, of course, the team will talk about this much more, but I just wanted
اس
to
پہ
give
بھی
you
ہم
a
بات کریں
brief
گے.
introduction
یہ
to
بھی
how we
بہت
work as a company. So
اہم کاوش
we
تھی
build
ہماری، جس کو ہم
upon
نے
Mo's
متعارف کروایا.
experience in
یہ
tuberculosis screening around the world, and then moved from
یہ
AI for
ٹی بی
TB
کی
to AI
سکریننگ
for
کو اے آئی میں
pregnancy-related
شامل
risk.
کر کے
And
پھر
that is because we
پیگننسی کے
saw that there
متعلق
were many
خطرات
women
کو
around
جانچنے
that
کے
would
لیے اس کو
die from
شامل کیا.
preventable pregnancy-related
بہت ساری
causes, and
خواتین جو
majority of
پریگننسی
these, the
میں،
far majority,
800
are now
خواتین جو
non-pregnant
پریگننسی کے
countries.
دوران جن کی موت ہو جاتی
And
تھی،
from our
ان میں سے
original
زیادہ تر
approach,
ایسی ہیں
we
جو کہ
believe that a problem that
کم
actually
وسائل والے
sits
ممالک سے
mostly
تعلق
present
رکھتے
in
ہیں،
LMIC
اور
settings
ان
really
صرف ان کو
requires a
اس
solution.
تک
And
رسائی
so
حاصل نہیں
we've
تھی، ان کو
developed
کچھ ایسی چیز
4
چاہیے تھی جو ان کے
LMIC
مسئلے
settings,
کا حل
taking
پیدا
into
کر
account
سکے.
infrastructure
ہم نے اس چیز کو مد
context,
نظر رکھتے
taking
ہوئے،
into account
وہاں کی
the
لمیٹیشنز کو
opportunities,
مد نظر
challenges
رکھتے
that
ہوئے
LMIC
اور سارے خطرات کو
have to
سامنے
deal
رکھتے
with on
ہوئے،
a daily
جو
basis, rather than
چھوٹے
taking,
ممالک میں، کم
ultrasound
وسائل والے
solution
ممالک میں
that
پیش
you
ہو
would
سکتے ہیں.
have in a hospital
ہم
here and
نے
there. Really
کوئی
developed
ایسی
a
چیز بنانے کا
management
سوچا جو کہ
solution
ہاسپٹل
that
میں ہو، ان
really
کے لیے ان
is
کے مسائل کا
designed
حل
for
سکے،
those places that face
جو
most
خاص طور
risk
پہ
of
ان ممالک
murder.
میں کام آ
And that
سکے
is
جہاں
how
پہ
we came
وسائل
up
بہت کم ہوتے ہیں
eventually
اور
based
صحت
on
کی
this
سہولیات
problem
بہت
with
کم ہے.
Baby Checker. So it's an artificial
اس
intelligence
چیز کو لے
solution
کے ہم نے
that monitors a
آرٹیفیشل انٹیلیجنس
transconcentric
بیس بیبی
ultrasound
چیکر
to
متعارف کروایا،
identify
جس سے
potential risks
الٹرا
of
ساؤنڈ کیا جا
pregnancy.
سکتا ہے
So
اور
again,
پریگننسی
really
کے
a
ریلیٹڈ
turnkey solution that's
رسکس
tailored to
کو
how these
جانچا جا
pregnancies
سکتا
resolve.
ہے
Turnkey meaning that like
اس سے
any
پہلے کہ وہ بہت
daily
شدید ہو جائیں.
TB, combining both the hardware, the software, being able to do the capacity
یہ ایک
building,
کمبینیشن
reversing
ہے
birth
ٹی
remote,
بی کی
and also
سکریننگ
the
کا اور
required
ایک ہارڈ ویئر کا اور سافٹ
after-sales
ویئر کا،
support to
جو کہ
ensure that
اس
these
قابل ہے کہ
projects can run
بلڈنگ میں رکھ کے بھی
continuously for
اور
many years
ایک
to
جگہ
come.
سے دوسری جگہ
So
لے
what
جا
we've
کے
really
بھی
been doing is
مریضوں
bringing
کو چیک کرنے کے لیے مدد کر سکتا ہے سال ہر سال
as
تک.
a total solution provider in this field, working on both the hardware
تو
side
ہمارا
and also
ادارہ ڈیلفٹ
in this case
انٹرپرائزز
providing the
نے
full AI
یہ حل
monitoring as well as
پیش
the
کیا
AI
ان
software
ممالک
to
میں
combining
جہاں پہ
capacity
اس
building
کی
and
بہت
service
زیادہ
all under
ضرورت
one
تھی
roof.
تاکہ لوگوں
And
کو
we're
وہ
really
سہولیات
bringing
میسر آ
that
سکیں پوری دنیا
experience
میں،
that we have on TB
جن
to
میں
all of those
جن
partners
علاقوں میں یہ
across
ضرورت
the
زیادہ
world,
تھی.
and leveraging it
خاص
now
طور
into
پہ
this new
ایسے لوگ جہاں پہ
relatively new area
ٹی بی کے
of
مسائل
AI
زیادہ تھے.
for pregnancy-related risks. So I just
اور
wanted
پھر
to
اس
give
کو
you a
اٹھا
short
کے ہم نے
introduction to how we
پریگننسی
work
اے
as an
آئی کو شامل کر
organization,
کے
where we're coming from, and the
پریگننسی کے متعلق
experience that
خطرات کو
we've built
جانچنے
in
کے لیے
TB and that we're bringing into
اور
this
ان کی
space.
شدت پکڑنے
I
سے
hope that
پہلے
you
ان
find
کو
the rest of the webinars and our speakers
تشخیص
interesting
کرنے
today,
کی
and that it gives you some
کے
useful
لیے
insight.
ہم نے اپنے
Thank you.
وسائل کو پورا کر لیا. آپ سب کو بہت شکریہ.
Thanks, Florent. As he pointed out,
فلورینٹ، آپ کا
equitable
بہت
health is the
شکریہ.
cornerstone of all our
جیسے انہوں
innovations
نے
here at Delft.
کہا
To further
کہ ہر
elaborate
کو
on this,
مساوی
I'd like to
سہولیات
invite my
ملنی
colleague,
چاہیے صحت کے لیے،
Sengwin,
اور
who
اس
will
میں
explain how
جدت آنی
baby
چاہیے.
checker is assisting in
اس چیز
maternal
کو
and
مزید وضاحت
neonatal
کرنے کے
health.
لیے ہمارے ایک
In
اور
her
کلیگ
presentation,
اینیا سے
Baby
بھی
Checker AI for
ابھی بات کریں
pregnancy
گے، جو
screening.
بیبی چیکر میں
Enya, the floor is yours.
بیبی چیکر اے آئی کے ذریعے بیبی چیکر کو
Hi everyone.
ماں
Thank
کی
you so
صحت کے
much
لیے
for
بات کریں گے.
coming to our webinar. I see a lot of
آپ سب کا مجھے یہاں پہ آنے کا بہت شکریہ. میں دیکھ رہی ہوں کہ بہت سارے اٹینڈنٹس اور ان کے پارٹنرز آ رہے ہیں بہت سارے ممالک سے، جیسے سیریا سے، سری لون سے، نائجیریا سے، کینیا سے، سینیگال سے اور ساؤتھن افریقہ سے بھی کوئی 100 کے قریب ایسے لوگ ہیں جو شامل ہیں. کچھ لوگ ادھر ہیں. اس ویبینار میں میرا رول یہ ہے کہ میں آپ کو بیبی چیکر میں ایسے سمجھاؤں کہ وہ کس طرح ہمیں اپنے ڈیلف امیجنگ میں شامل کیا اور کس طرح اس کو کون کون سے عناصر اس کو بروے کار لایا سکتے ہیں ان ممالک میں، خاص طور پہ جہاں پہ بہت زیادہ کم وسائل ہیں، اور ان میں جدت کو شامل کرتے ہوئے ایسی کمپلیکیشنز کو ٹیکل کرنے کے لیے. ہم نے 6 سال پہلے جب بیبی چیکر کو شروع کیا تو یہ ہمارے لیے ایک بہت ہی نئی چیز تھی کہ ہم اس میں چھلانگ لگائی. جب ہم نے ہماری کمپنی نے ہمیشہ سے ایسے میڈیکل ٹیکنالوجیز کو شامل کرنے میں کوشش کی جس کے لیے کوئی بلڈنگ کی ضرورت نہ ہو، اور ہم پہلے رہے ہیں ایسے جس نے کمپیوٹر کو شامل کیا آرٹیفیشل انٹیلیجنس میں اور میڈیکل کی تصویریں لینے میں. یہ سارے نقطوں سے ظاہر ہوتا ہے کہ ہمارے سوشل انٹرپرائزز کے طور پہ ہماری بنیاد میں یہ چیز شامل تھی کہ ہم جو کچھ بھی کر رہے ہیں یہ ان ممالک کے لیے جو کم وسائل والے ممالک ہیں، جیسے کہ خاص طور پہ ان صحت کی سہولیات جہاں پہ نہیں پائی جاتی. ہم نے بیبی چیکر کچھ خاص بنیادوں بیبی چیکر کے بارے میں کچھ خاص نکات شامل کرنا چاہوں گے جس سے آپ کو سمجھ آ جاتی جس وجہ سے ہم نے بیبی چیکر کو شامل کیا. ہر منٹ میں 2 خواتین کا انتقال ہو جاتا ہے بچے کی پیدائش کے دوران، اور ان میں سے 95% ان علاقوں سے ہیں جہاں پہ صحت کی سہولیات اور وسائل بہت کم ہیں، جس سے ہمیں یہ بھی پتہ چلتا ہے کہ الٹرا ساؤنڈ کی اہمیت کا اندازہ ہوتا ہے کہ پریگنینسی میں اسکریننگ کرنا کتنا ضروری ہے. اسی وجہ سے ورلڈ ہیلتھ آرگنائزیشن نے اس کو ریکمینڈ کیا کہ الٹرا ساؤنڈ ہونا چاہیے پریگننٹ خواتین کا، جس سے یہ اسکرین کیا جائے. بیبی کے حمل کے شروع کے دوران ہی زیادہ سے زیادہ الٹرا ساؤنڈ سکین کر کے اس کی پیچیدگیوں کو تشخیص کیا جا سکتا ہوں تاکہ پھر اسے علاج کی طرف بھی جایا جا سکتا ہے. ہم آپ کو یہ بھی بتانا چاہیں گے کہ بیبی چیکر ہے کیا. بیبی چیکر ہماری بنیادی صحت کی سہولت ہے، خاص طور پہ ان ممالک میں جہاں پہ وسائل بہت کم ہیں اور وہاں پہ کوئی کسی بیماری کا پہلے سے تشخیص ہو جانا بہت زیادہ ضروری ہے، اور ہر کسی کو مساوی صحت کی سہولت ملنا ہمارا ٹارگٹ ہے. تو بیبی چیکر کی بنیاد کہاں سے بنی اور ہم نے اس کو کیسے ڈیلف آپریشنز میں ہم نے اس کو شامل کیا، وہ یہی وجہ تھی کہ ہم لوگوں کی پریگنینسی کے دوران پیدا ہونے والی پیچیدگیوں کو پہلے سے تشخیص کر سکیں اور جلد تشخیص ہونے والی بیماری کا ایزی سے علاج کیا جا سکے، خاص طور پہ ان ممالک میں جہاں پہ صحت کی سہولیات بہت کم ہیں اور وسائل بہت کم ہیں. تو بیبی چیکر کا بننا آرٹیفیشل انٹیلیجنس سے خاص طور پہ ان مسائل کے حل کے لیے تھا جو ہمارے ارد گرد بہت ساری پیچیدگیاں ظاہر کرتے ہیں، جیسا کہ ایک موبائل اپلیکیشن ہے جو کہ جس کے ساتھ بیبی چیکر کو اٹیچ کیا جا سکتا ہے، اور آرٹیفیشل انٹیلیجنس اس سے سکین سے یہ چیز نکالتی ہے کہ کون سی پریگننسی رسکی ہے، کس پریگننسی سے نقصان ہو سکتا ہے، اور اس کو اس سے کنیکٹ کرنا بھی کوئی اتنی مشکل نہیں تھا. تو بہت سارے لوگ ایسے تھے جنہوں نے کبھی اسمارٹ فون استعمال ہی نہ کیا ہو. اس چیز کو آسان بنانے کے لیے ایک ویڈیو شامل کی گئی موبائل پہ جو کہ بڑی آسان ہے، جیسے کہ ہم نے پہلے مینشن کیا، پھر تصویر بھی دکھائی ان کی۔ ویڈیو میں وہ ساری وضاحت موجود ہے کہ ہم اس ویڈیو میں بیان کیا گیا ہے کہ اس بیبی چیکر کی اپلیکیشن کو کس طرح استعمال کرنا ہے اور کس طرح ہم اس کو استعمال کر کے ایک پریگننسی میں ارلی اسکریننگ کر سکتے ہیں، جس سے ہمیں کسی پیچیدگی کا پہلے سے پتہ چل سکتا ہے۔ پھر ہم نے یہ بھی کوشش کی کہ اس کا وزن کم سے کم اور ٹائم کم سے کم رکھا جائے تاکہ یہ جلد از جلد لوگ دیکھ کے آسانی سے اس کو سمجھ سکیں۔ تو یہ اتنی آسان بنا دی گئی ہے کہ اس سے ہر عام اور خاص اس ویڈیو کو دیکھ کے آسانی سے سمجھ سکتا ہے۔ ایک اور ویڈیو بھی ہم نے شامل کی ہے جو کہ اس ایپ کی ٹریننگ کے بارے میں ہے کہ اے آئی کیسے کام کرتی ہے۔ تو ہم نے پھر اس میں بیبی چیکر میں کچھ بیبی چیکر شامل کیے جن کے مختلف خوبصورت رنگوں میں تھے، جیسے اورنج اور پرپل اور اس طرح کا کیس ہے۔ اور یہ بہت ضروری ہے کہ ہم یہ سمجھیں
building a validated and growing artificial intelligence, which you will hear more about by my colleague Julio, who's leading that. It's been important to build a solution that is easy to use and that our end users actually enjoy. And that's something that often is not spoken about at large. We focus a lot on AI, and that term has been everywhere, especially in the past year. So my main point here was really to kind of zoom out of AI for a little bit, even though AI is part of our webinar title, to really, cast some light on the importance of other aspects that surround the AI, that make it more human, that make it more palatable, usable, and also reflective in a sense that we as a company in building Baby Checker into what it is today have always been very receptive to what users have to say and what their opinions have been on the product since it was a prototype. And of course, how you get that sort of feedback is based on years of relationship building and trust building in the communities. So Julio and I actually just got back from Sierra Leone yesterday, where we have our longest running research project. And so that research project, especially amongst many others, has been really key in building this product because of those years of relationship building with the end users, with midwives, traditional birth attendants, CHWs, etc., to really know more about whether they enjoy using Baby Checker, whether they can use Baby Checker, so optimizing the training and the app to make sure that they can use it, and also whether it empowers them and helps them do their job, which is already so important and so packed with so many things. So many of these health workers are out on training, once a month. Sure here and there. Enya gets online. Enya, can you hear us? Yes. Can you hear me? Yeah, I can. Okay, I can hear you now. Thanks. Perfect. So where I left off, I hope, was about our receptive product development method, which has really been used on or been built on the cycles of hearing user feedback, like all the people you see in the picture right now, which is, of course, just a snippet. It's from Zambia to Tanzania to Kenya to Sierra Leone. All the pictures you see right now have really, these users have really formed what Baby Checker is today. And of course, our technological innovations would never reach the intended beneficiaries if it wasn't for our partners. So from our research partners like KIT, the Royal Tropical Institute in the Netherlands, to Radboud UMC here in the Netherlands as well, Lionheart Medical Center, the District Health Office in Tonkolili, Sierra Leone, amongst many others. And our suppliers, of course, Fairphone, Telemed, and all the other organizations, and of course, our partners and the early adopters and clients of Baby Checker that have made this possible and have continued to help us improve Baby Checker from the point that it is today. So I will close my presentation here, and I just want to say, thank you very much for attending this webinar, and thank you for our speakers, which you will hear about very soon. I've met all of them in the past couple of years, and they all have played significant and different roles towards Baby Checker, from
being a sort of early adopter and putting the baby checker into mobile clinics, to researching usability and implementing baby checker in public health facilities in Kenya, which you will hear a lot more about in a second. So thank you very much.
Thank you so much, Enya. Like she pointed out, it's extremely important to remember the human side of this as well. AI by itself is nothing if you don't count in the people who make it work. On that note, before I move into the next speaker, I just want to kindly remind all our viewers today that if you have any questions about any of the upcoming presentations, please make sure that you put your questions in the Q&A section so that our experts can answer it at the end of the webinar. Okay, now I'd like to invite Tafadzwa Kalisto Munzwa, the co-founder and the executive director of Dawa Health in Zambia. Today, he will be talking about the preliminary finding on AI-driven non-invasive anemia detection using a smartphone application. Welcome, Tafadzwa.
Thank you for having me, Katia. And good afternoon, good morning, everyone, depending where you're calling me from. I think I can just go on into how we've been using Baby Checker really in our mobile clinics and now also in slum communities where we still have a lot of challenges with regards to accessibility of diagnostic technology, and how we really have been leveraging AI, including Baby Checker and other tools we have incorporated in our work and research as well. Next slide, please. Dawa Health is a company we started about 4 years back now. And the initial spark to the work we are doing now was my cousin at the time. So you can see that in low and middle income countries, this problem is really non-selective in who it affects. So my cousin at the time had a bit of pregnancy complications, which eventually resolved her, and her baby and herself were eventually stable. But that was the initial spark. And with my background training, which is medicine, I started really thinking around how could we use technology and innovative ways to reach more patients or more people like my cousin and to make a difference in their lives. So we have built that over the years, and we've incorporated and evolved over time, which I'll briefly talk about, and also the tools we're using at the moment. Next slide, please. So this is a big problem or colossal challenge I decided to dedicate my life to, which is reducing maternal mortality in sub-Saharan Africa. So if you look globally, about 70% of the daily maternal mortality in the world happens in low and middle income countries, and sub-Saharan Africa is massively affected with that. So this is just a comparative analysis of, you can see the maternal mortality per 100,000 women across sub-Saharan Africa and across Europe. You can see the significant difference that more than 533 mothers are dying from preventable pregnancy complications in sub-Saharan Africa compared to just about 6 in Europe, which really emphasizes on finding innovative ways that can make a difference in life-saving going forward across our region, with what's been done before, not really solving it to the extent we want it to. Next slide, please. So this is the current state of maternal health in Zambia. And like I mentioned, about 70% of maternal mortality is still in sub-Saharan Africa. And in the markets we are working in right now across Zambia and Zimbabwe, you see that about 15 mothers are dying daily from preventable pregnancy complications, which is totally unacceptable. That someone would die from, example, postpartum hemorrhage, which could have been prevented with the right screening tools, which I think Baby Checker does to a significant extent, and some of the tools we are doing. And another challenge we got to see in these communities we are working in is that most patients or most mothers present for antenatal pretty late. So they're usually coming in the second trimester, around the 5th or the 6th month, which is usually later than we want them to. As health workers, we want a mother to come in the first trimester because that's when you can significantly make a difference and advise them or do the necessary interventions to prevent a complication setting in. And from what we were doing early on, maybe from the last 2 years, we got to see that even though about 40% of the patients receive antenatal, it's still not significant enough. And I think like what Enya alluded to earlier on, most mothers, you find that they've never had a scan before, and this is their fourth pregnancy. And you're like, how is that possible that someone is able to, have so many children and not have quality antenatal? So antenatal is still pretty significantly poor, even if, part of the population are receiving it, which is some of the problems we want to address. And we have a lot of undiagnosed high-risk patients, from things like low-lying placenta, which is what we call placenta previa medically, to things like anemia in pregnancy. These are some of the risk factors that can be intervened early on and correctly and to prevent complications setting in. But most patients go to delivery without that being done, and possibly explains why we still significantly have high mortality rates in our region. And one also issue of the current system or health system in sub-Saharan Africa, Zambia to be specific, I don't know other setups, is you usually have your clinic or your hospital dedicating a single day in a week where they call it an antenatal week. So you find that that day might not be comfortable or flexible for every mother to come in. And also just generally how the attitude of the health workers is still a challenge. So those are some of the challenges that still exist, in these setups, which we're hoping to address, incorporating our model and innovative tools like the baby checker going forward. Next slide, please. So the solution we've built at Dawa Health over the last 2 years or so is an integrated, holistically approach to maternal health. So we have internally built a tool that helps us identify the necessary, parameters when talking about maternal health. So it looks at things like past medical history, takes a look things like, the observations that have been done, demographics, a number of things. And using that data, we're able to kind of predict potential risk. Then that goes on to the mobile clinic vans we have. So they go into the communities usually where you don't even have a local clinic, and we're able to partner with either local pharmacies or markets there. Then patients are coming into the mobile clinic for a comprehensive maternal, interventional support. So in the mobile clinic, that's where you have tools like the baby checker that are supplementing our internal house, a predictive platform. And with this, we're able to kind of give a comprehensive support to maternal health, identify high-risk patients. If they need early referral, we refer them to, advanced centers where the appropriate intervention can be done. And we supplement this by a network of community health workers. So in the communities you operate in, you have local custodians who have the social capital, who are trusted, who've been in these communities for a very long time, that are able to mobilize patients to come in to access services at Dawa Health, making it useful, right? Because a tool like Baby Checker would need the patients to come in and seek the healthcare. But you will see that in low and middle income countries, it's more than just the diagnostic tools, it's even the attitude and behaviors. So we're trying to also tap into that and, kind of champion people seeking healthcare early and getting the right healthcare, which has significantly, in our pilot over the last year, we've been working with Baby Checker, reduced the average first antenatal point of contact from about 6 months to between 1 month and 2 months, which makes a significant difference in us allowing us to support and identify potentially high-risk mothers in intervening time. Additionally, we've added on a hybrid pharmacy that enable us to retail things like your folic acid, vitamins that might be needed during pregnancy to supplement a mother, providing the right nutrition and, right oxygen to the baby. And lastly, we are also essentially incorporating last mile logistics. At the moment, we have a network of motorbikes that deliver these things to our community of flow workers. Next slide, please. So this is essentially just a summary of how the whole concept works at the moment. So we essentially onboard community healthcare workers who we then give training on how to mobilize the population, on how to essentially tell them about Baby Checker, the advantages it comes with, and the other tools we incorporated, and where they can find us through our mobile clinic vans, through our partner slum clinics as well. Then we're able to essentially do the needful triage and essentially support the mother accordingly and rightly. Next slide, please. So these are some of the tools we are currently using in our mobile clinic vans and in our model. So we are using the Baby Checker powered by Delft. So with this, we're able to potentially identify some of the high-risk mothers, and we've been able to identify a number of them. And the outcome have been good because of that early detection. We've also additionally added a Gen II into our channels, which is WhatsApp, mobile app, and web. This allows mothers to access the right validated medical knowledge in their native language because it's able to do interpretation between languages. And we're able to also now do anemia detection, which is part of the tool I'll talk about in addition to Delft. That's essentially looking at the conjunctiva. Then it's able to approximate the hemoglobin levels and how that essentially help us manage patients who are potentially high risk, adding to what Baby Checker would be able to identify. Then we're also doing a predictive algorithm on our platform, which has been supported mainly by MIT Solve, which I talked about earlier on. Next slide, please. So I'll go into this case study. One of the interesting case study we recently had. So we operate in a number of slum communities in Zambia at the moment. And one of them is Ngombe, which is a significantly underdeveloped area, but with high population density. And you find that you have a lot of teenage pregnancies, you have a lot of high-risk pregnancies in that area. So we had a female 23-year-old who came. She was around 36 weeks, 3 days at the time. She had our first point of contact with our team. And we were able to essentially look at how big the superficial frontal height was, about 36 centimeters. We did the BP profile, which is around 128 to 78 millimeters of mercury, and pulse was around 82 beats per minute. So if you see, before we had incorporated Baby Checker, if you see such a patient, as a health worker, you'd assume everything is okay, and you'd send such a patient back home, not knowing that she's even a potentially high-risk patient. Then when she goes to her local clinic to deliver, you find that this patient would likely bleed on the table and potentially die. Why? Because their placenta is low. This is something as clinical or as health workers, we're not able to tell clinically. But with such a tool like Baby Check, as you can see our team here using it, we were able to identify that this patient had a potentially low-lying placenta, which is what I said, placenta previa. So placenta previa, essentially, when the baby is coming out through the birth canal, they're essentially able to cause trauma to the placenta, which would cause excessive bleeding, and a patient can die from that bleeding. So you can see that with a tool like Baby Checker, we were able to pick that early on, and we were able to know that this is not a case you can manage at a low-level health clinic. So we referred this patient to a teaching hospital where they were able to be assisted, and the mother was able to be stabilized, and the baby was delivered, and the baby was okay. At a score of 8/10 under the first minutes, the 9/10 under 5 minutes. So you can significantly see how in the real world a tool like Baby Check is actually making a difference, because we're able to identify some of these potentially high-risk patients who would otherwise maybe succumb to whatever undiagnosed conditions they have. And a tool like this would help in the management and early referrals and really make a difference in the last mile. You go on to the next slide. Yeah, so AI-powered non-invasive anemia detection tool, which is supplementing the work we're doing with Baby Checker. You will see that some of the patients who succumb to what we call postpartum hemorrhage is essentially any blood loss that happens during giving birth that would essentially lead to hemodynamic instability, or essentially someone going into shock, what we call medical shock. So you can see that a placenta like Baby Checker helps us identify before it happens. Then a tool like the non-invasive anemia detection enables us to identify the level of the blood in a patient before they actually go for delivery. So with this, we're able to see that about 80% of the patients in our early access pilot were anemic. So essentially, they had blood levels that were lower than what we medically recommend. And when patients give birth, they're likely to go into shock. This might be even with placenta previa or with other conditions. So such a tool is helping us really comprehensively support a patient, that we might be able to see, okay, the low-lying placenta is not there in Baby Checker, but this is a patient who has low blood. So even if they give birth at their local clinic, there's minimum bleeding on giving birth regardless, right? So that can still cause a patient to go into shock. So these such tools that are AI are kind of comprehensively helping our clinicians in the last mile make the right clinical decision to say, okay, with this, we're able to refer this patient, we're not able to support such a patient. So that's how significantly AI is really making a difference in the last mile and making, a change in the communities we are operating in. You can go on to the next slide. Yeah, so this is essentially just going a bit into some of the research we've been doing in-house, some of it with ڈیلفٹ, some of it with other partners, which is essentially trying to just improve the AI long term. So this table was just, we were doing a comparative analysis between, the non-invasive anemia detection tool and the standardized lab test to help us build into that data set, which eventually, have good clinical outcomes. So you can go on to the next slide. Yeah, so this statistical analysis was just essentially looking at some of the hypotheses we have to say, okay, where is AI at the moment, especially for the non-invasive anemia detection, comparing the mean differences between, the AI one and the lab standard, so that we continuously improve using the pictures we are capturing from, the smartphones or the non-invasive to make it significantly be good. So as you can see, I'll just summarize this. There's still more work that needs to be put in to make some of these tools really clinically significant, which is essentially what ڈیلفٹ also talked about, the research they're really doing on the ground to really make these tools validated and clinically significant so that they can be scaled to people who otherwise before didn't have any, screening or diagnostic tools. Yeah, so this is just a summary of that. Next slide, please. Yeah, so this is essentially the question we've been asking ourselves internally. How can we really improve tools like the baby checker, tools like the NIADA, to really be at par with some of the clinical tools, and that can be scaled at large scale. So the recommendations we have decided to stand on with my team is we need more interventional studies or clinical trials, which we're already doing at Dawa Health, to really improve such tools that when they can be scaled, they'll be accessible to more people because we have validated work in such environments, in such setups. We've really also been looking at how can some of the model can be recalibrated. What are some of the challenges in making these tools be accurate or be at par with big expensive tools at the hospital setups. We've been also trying to look at bias analysis, which is a challenge with AI tools, of course. How can we reduce bias in terms of the data sets being built, and collaborating with partners like ڈیلفٹ? We hope that would significantly improve, the data set to have, representative of, the population or the communities we are trying to scale these tools in. And also we are hoping to have explainability on how AI tools will understand some of the results and make a difference. So yeah, this is essentially, our recommendation as we are building in-house and also with different partners. You can go on to the next slide. Yeah, so this is the impact so far we've been able to currently have significantly in the communities through the partnerships we have with companies like ڈیلفٹ, with the baby checker and other partners as well. We've supported over 7,000 patients already, and we are significantly trying to scale this by end of 2025 to between 20,000 to 30,000, which will really make a difference in making such tools accessible, help reducing some of the complications like postpartum hemorrhage, things like preeclampsia and other things. Some of the things I touched upon them earlier on. I can go on to the next slide. So this is some of the testimonials we are getting from patients who have benefited from baby checker and the model we've essentially developed. So they're really loving the difference such scans make. So you find out that one way patients are now referring to Dawa Health is the place where you have multiple tests done. So they love the baby checker too. They're saying this is a really advanced tool. Why don't other facilities have them? So we just so that's the kind of brand identity people are starting to identify us with, and the extension of our community healthcare workers. So you can really see people now being motivated to come in for antenatal checks, to come in for support and all that, which really at the end of the day will translate into the impact going forward. You can go on to the next slide. So essentially I'll ask, in case, of course, on the panel, there are people who want to partner with us to do collaborative research to improve continual testing, improving AI tools in low and middle income countries, and also partners who might want to support research, whether in terms of funding, in terms of expertise and all that. We're definitely hoping we can continue building this work, which will really make a significant difference in low and middle income countries in a couple of years when such tools are scaled at large, and it's more accessible and making a difference in our communities. Next slide, please. Yeah, so essentially this is my team I've been working with over the last 2 to 4 years, helping us make some of the differences. I just wanted to appreciate them, that people see the amazing people who've been behind this work, and some of our research collaborators as well, who are helping us champion this work in the low and middle income countries like Zambia and Zimbabwe going forward. Next slide, please. Yeah, so in a summary, I think that's it. Thank you, everyone, for paying attention and listening to the work we're doing, working with Delft and trying to scale this work of maternal health and accessible AI in the last mile. Thank you so much.
Thank you, Dr. Munzwa. Dawa Health's work in Zambia is truly phenomenal. A kind reminder to all our audience members today, please make sure that you write your questions in the Q&A section so that our experts can answer it at the end of the webinar. Also, to all our speakers, we truly welcome you to this webinar. We would really like if you continue presenting like this. Now, I'd like to invite Dr. Gregory Ganda. Dr. Ganda is the country executive committee member for medical services, public health, and sanitation at Kisumu County, Kenya. Today, he's going to be discussing how he and his team are leveraging AI ultrasound, risk flagging, and digital records for better outcomes in Kisumu County. The floor is yours, Dr. Ganda.
Very much, Katia. Probably move the next slide, the first slide. Thank you. I think that's me. I'll be talking to you about how we are leveraging on AI ultrasound, risk flagging, and digital health records for better health outcomes in Kisumu. My background is actually gynae-oncology. I'm a gynecologist who's practiced gynae-oncology and currently working in Kisumu. Next slide, please. I'm happy my colleague has talked greatly about this background, about the maternal deaths that are occurring globally, around 287,000. And he focused on the high percentage that is occurring in middle-income countries, basically the sub-Saharan Africa. And what we are saying is that 70% of them are actually driven by delays in care and resource limitations. So we in Kisumu are also in this journey. Kisumu is one of the counties in Kenya. Kenya has a devolved system of government. We have 47 county governments, and Kisumu is one of the counties along the lake. We are in Kisumu, our goal is to reduce maternal and newborn mortality by 80% by the year 2026. It's something that we've been doing over the last 6 years, and I'll be showing you the statistics so far. We've been able to do that by around 30% right now. And we want to pioneer evidence-based quality care for healthier moms and babies so that we enhance value-based care. Next slide, please. So in the background, this is Kisumu. We have 338 facilities, which is spread around dispensaries, health centers, and sub-county hospitals, usually in 4 levels. We have level 2 and 3, which is the dispensaries and health centers. And then we have level 4, which is the referral facilities, the primary referral facilities, and the level 5, which is the referral facilities for those level 4s, which is the higher, what we call them, county referral facilities. These are our indicators. If you look at 2014 and 2022, by the demographic health survey, I'm particularly going to look at health facility deliveries. At that time, we were doing, in 2014, we only had 69% of mothers delivering in facilities, actually 61%. Based on the numbers, those are two different numbers. There's the Moxar survey of 69.5%, but we were able to increase that to 94.4% by the year 2022. But if you look at lower down at the maternal mortality, we were able to reduce maternal mortality from 495 per 100,000 to 343 per 100,000. That is quite a big reduction of 30%. And the infant mortality and under 5 mortality is also reduced during this time. And the issue was that we were able to drive the numbers from the community come to the facilities. But if 94% of the people are delivering facilities and you have a maternal mortality of 343, it means then that you are not offering quality, and the quality that you're offering is not good enough. And probably you are not preventing as many maternal deaths as you should have been preventing. And that is where we are starting from in our next phase from 2022 up to the 2028. Next slide, please. So the issue is high burden of maternal and perinatal mortality that I've talked about. But the bigger issue is that we have poor access to quality services in the rural sub-counties. I would have shown you a different slide that shows you we have Kisumu as a center with a large referral hospital called Jaramogi Referral Hospital. And we have another one called Kisumu County Referral Hospital. You find that the percentage of deliveries that occurs in these two facilities in this sub-county is almost 150%. And that tells you that the number of people who attend antenatal clinic vis-a-vis those who deliver, many more deliver than those who attend antenatal clinic. Meaning then that we have women who travel from quite long distance to come and deliver in the facility. And why we think that is so is because the facilities which are in the peripheral typically are inadequately staffed, and they have inadequate skilled staff also. They have less numbers, but also the skills are less. And so what happens is that when mothers get poor outcomes in these facilities, they get discouraged because one mother tells the other, no, I think that place is not very good. And when they hear that there's a better facility, then they wait to travel to that facility. Sometimes they don't have transport. So the first thing that it causes the first delay, they cannot decide to go to the facility. Then after that, when they decide, now I think there's a problem, you have a long distance to travel, and all these things lead to poor outcomes and delays. And so what we want to do is make sure that whatever is going on in the peripheral facilities is quality. And go to the next slide. And this is our cycle that we think is going to happen. If you look at the top, I think the top of the circle, if we improve the quality of care at the primary healthcare facilities, two things will happen. One, these facilities will be able to detect who needs to be referred and who needs to be seen at a higher level facility because there are more complicated cases. But secondly, it will improve the patient's journeys and their outcomes. They'll feel that they have been well taken care of and they'll get a good outcome. And so they'll be happy. And when they're happy, it encourages more people to use the primary healthcare facility. And when that happens, the revenue for that health facility improves. And when they have more revenue, it means they can increase the investment in that facility to again improve the quality of care. And that cycle is what we are trying to break. Usually I say what comes first, the quality of the money, the investment before the quality, or the quality before the investment, whichever way you look at it. But the investment needs to be done for you to start seeing that improved quality. And that's what we want to do here in Kisumu. Next slide. So what's the ambition? If we digitally connect all these people, then we will be starting to solve our problems. We want to develop a digitally enabled infrastructure at all levels of care for quality maternal and child health for mothers in Kisumu, so that we never lose track of a mother and her baby throughout her journey. That means that we want to register you from the time before you even get pregnant to the time you get expectant, and know your journey, know what is going on, follow you up until you deliver, and follow up your baby until the baby finishes the immunizations. And what you want to do is leverage on technology, because we know the problems that I've talked about. Peripheral facilities have less people, they have less experience. How do we make that experience from the hospital go all the way down there without having to look for somebody who has experienced work down there, because we know all over the world, most people who are experienced want to earn more money and they want to live in the cities. Next slide. So how does AI come into this? One, we want to bridge the resource gaps through early detection, monitoring, and decision-making using AI. And what are we going to use? We are going to use electronic records for the mother and the child, because the first, for you to use AI, it means that you must have data. You must have information flowing in. So we want to have all the information flowing in. Whatever happens to the mother, whatever happens, whether in the community or in the facility, that has to go to an electronic record. Now, from that electronic record, then the AI can be able to flag those who are at risk or those who need to be referred, and actually sometimes advise the client, the mother or the health worker on what needs to be done. So we have two tools that we are currently piloting. We started this program, I think, 3 months, 6 months ago. One, we have the Wonder electronic medical records, which basically is going to do two things. One is going to collect all the information about the mother all the time, from antenatal clinic to delivery to postnatal to the mother. And what Wonder EMR has is that it has an inbuilt maternal early warning sign, meaning that whenever this information comes into the application, it can flag the people who are at risk and becomes an early warning sign for the clinician and for the mother. So that AI-enabled real-time alerts for those anomalies will be given to the facilities so that they're able to see. And there will be 3 bands. There's a red band, a yellow band, and then a green band. A green band means there's no problem, but a yellow means that there's something that needs to be checked. And the red band means that there's something that urgently has to be followed up. The second thing we're leveraging on is AI-enabled portable ultrasound for fetal maternal monitoring, and that we are using the ڈیلفٹ imaging ultrasound for that purpose. Next slide. I think I've talked about this. The Wonder EMR monitors mothers in antenatal and postnatal changes and generates real-time alerts, red alert and yellow alert. Red for high-risk anomaly, that's a deviation from the normal, and yellow for mild to moderate risk anomaly. And the ڈیلفٹ baby checker is a portable AI ultrasound. We have put it in wards. Actually, when we have a county, I didn't explain to you how a county is in Kenya. A county is further divided into sub-counties, and sub-counties are further divided into wards. And a ward is a cohort of people. So we are piloting the baby checker in one of our wards for the last 1 month. And the first pilot really is not to look at the outcomes, but to get the change management, to let people understand what this thing is all about and let them incorporate it into their day-to-day work. We are hoping that in the next 1 month, once they're used to it, we will incorporate these findings into the EMR so that the information goes automatically. And so far, in the pilot, we've been able to do 103 scans. Next slide. This is basically a map of the area where we are piloting it, and we want to build on the infrastructure and the technology that already exists. One of the things that Kenya has moved towards is that Kenya has decided that primary healthcare is very, very important, and Kisumu is taking a lead in this. So we have formed what we call primary care networks. And primary care networks are facilities which are working together to take care of a population. And so in this area, you can see the facilities which have circles around them. That circle is actually the distance, around 2 to 3 kilometers from that center. And all those dots and pluses are facilities which are in that area. If you look on the left side of your slide is where we have your referral facilities. The largest referral facilities in JOTRH in red, and then KCRH down there in green. And so all the facilities on the right refer all their complicated cases to these 2 facilities. But we want the facilities, the bigger facilities, if you look at Gita down there, St. Elizabeth, Chiga, and Nyalunya Health Center, which have pluses and big circles around them, to be like the sub-hubs where we can be able to take care of the population, and then they will serve the smaller facilities. Another thing we've done in this country, and I think my county was ahead in terms of digitizing a community health system, is that we have digitized our whole community health system and have an electronic community health information system where we register each and every household, and every household has a file, and we know how many mothers are there, how many children, how many men, and what is the living condition like. And these are the things that we want to leverage on in our system. Currently, we are, and our primary healthcare facilities are undergoing digitization, and we actually want to digitize reproductive health. We are starting with maternal and child health clinics in all these facilities that I've talked about into this system. And we also have the district health information system, and this is usually collected at the end of the month by our teams. Now, another thing you will notice is that some places have more facilities. If you look down there, Nyalunya, towards JTRH, because the population is higher, and these are the black places are mainly, most of them are private facilities. And so we are leveraging also on making sure the private facilities become part of this network, because they also see our mothers. Now, all this infrastructure that we built is what we want to leverage on to have AI enable assistance to our people. Next slide. Next slide, please. Yes, so this is the pilot project so far, 6 months. We started from the 2 facilities I talked about, the referral facilities, because we needed to first of all find out if the EMR works, what do we need to add. We needed to look at the flagging, because once the EMR shows a flag, like a red flag, it straight away advises the healthcare worker what they're supposed to do based on the standards that are available in obstetrics and gynecology. So we have 8 facilities that we are scaling to as we speak. So far, we have scanned, or not scanned, we have seen 2,626 mothers in antenatal clinic since May 2024. And the high referral facilities where we started from, the Kisumu County Referral Hospital, had 1,508 visits. And the Railways Health Center is a smaller facility, has recorded 846 visits, and the rest of them have come from the peripheral facilities that I've talked about. Peripheral facilities just joined in, I think, around a month ago. We have red and yellow alerts guiding the interventions to be done. And we have started looking at the early detection using abnormal readings, for example, of BP, fetal heart irregularities, and all those kind of things that come into the antenatal clinic, including your antenatal profile. All the information which goes into the EMR are actually used to develop an early warning sign. We are yet to start a community early warning site that actually looks at mothers, and whatever they ask, they're able to communicate with the facility directly. And there's some questions which, when you ask, are actually a red flag. That if you ask, I've seen some spotting and you're late into your pregnancy, that's a flag. So we are yet to incorporate the community information into this system. We have done community engagements at 2 of our facilities in Angola and Chega so far within the last 1 month. Go ahead, next slide. So I note that we've used the POCAS for the last 1 month, and so far, from May to November, we are having almost 60 red alerts monthly. And what happens with these red alerts is that the facility is informed, but also we have the gynecologists at the main center who are informed at the same time. And what has happened is the ward practice groups have formed groups. When there's a red alert, it will be alerted and sent in the group. And you'll have to explain what you've done to that particular mother who's on a red alert. And if you didn't do, then there is somebody at the background, a gynecologist, who checks a day later to find out what happened to this mother. In terms of POCAS, we have started scaling this to underserved areas. If you looked at the last slide, the places that I've said are bigger facilities where we want to have the point of care ultrasound. And you realize the peripheral facilities sometimes have very low numbers. So it does not make sometimes economic sense to have one of those POCAS machines in a facility, because they might be seeing 2 mothers in antenatal every day. And that might not give you enough the numbers. And so you need a machine that moves around. So what we are doing is that we are developing a system where the mothers can be booked for scan on certain days, so that every day we know where the AI ultrasound is, and the mothers get this done routinely in their clinics on their booked day. Next slide. So this is the slide showing the antenatal clinic from May 2024. So far, we have had 393 red alerts out of 2,200 and something visits that I showed you. But what I want you to note in this slide is that out of all this, we have not noted any fetal placental anomaly, even in the largest facility. And the fetal placental anomalies I'm talking about are multiple pregnancy, placenta previa, inadequate polyhydramnios, and all those anomalies which you usually see in the fetus or in the placenta. And that is why ultrasound is a very, very important component, because you might think even where there is high volume and you have an ultrasound and a sonographer who has been employed, it becomes very difficult for a mother to get booked to go to the ultrasound room. They get lost in between and they don't do the ultrasound. And so you can imagine that out of 2,200 people we saw, we are not able to flag a fetal placental anomaly that needs our attention. And again, on the other side, you look at the women or the caliber of people we are seeing, 60% are between 20 to 30 years of age, but we have a significant percentage of teenage pregnancies, almost 20% in these people that we have seen. And these numbers are even worse if we move to the peripheral facilities, where we have up to 40% of mothers being teenagers. Next slide. So what are the challenges? The challenges, one is distance to be covered for ultrasound sharing. We're trying to work out how we can look at the issues of transport for these mothers when they're going to this peripheral facility, or for the healthcare workers, which have low number of antenatal attendances. And I think I've talked about that. And the second thing is sometimes we have inconsistent internet connectivity, and that means that the information sometimes is not live. It has to be synchronized when the machine comes or our tools come into the space where there is internet. The biggest thing again is resistance to new technology amongst healthcare workers. People are used to the big old machines where you scan and you see a baby, and it takes time for you to change people's attitudes towards the technology. And there's also limited awareness of the patients on AI tools that actually you can just scan and then everything is given to you. And it is almost as accurate as a human being. Next slide. Next slide, please. So I'm not going to go through all these recommendations, but basically we need to be able to scale up the AI applications, extend monitoring to inpatient maternal care, incorporate predictive analytics for even postpartum complications. We need to do capacity building for healthcare workers, for the community on AI. We need to talk more. We need to have these webinars. In terms of policy, we need to look at increasing funding for sustainable AI interventions, because sometimes, even in my country, most people don't think AI intervention should be paid for. They think that you should see a human being for that to become a service that is paid for. Even though we know that the AI sometimes is just as good and will give you the quite good information. We need to be able to look at how we integrate the AI tools into the programs, strengthen our infrastructure, and establish robust data management systems that incorporates AI. Finally, next slide. Looking forward, we are championing AI integration in maternal health care systems. We want to support policies to sustain the funding for AI programs, and I think that's what I've been doing for the last 2 months. We want to promote multi-sectoral collaboration to scale and refine these tools, and prioritize training to ensure readiness for AI-driven healthcare, because that is the future. We can't run away from it. No mother or newborn should die from preventable causes in this day of this era. Thank you very much. Last slide. Thank you very much. I think that was my last slide, and I'll welcome any questions later on.
Thank you so much, Dr. Ganda, for your valuable insights on how AI can assist and definitely not replace humans. Please remember to put your questions in the Q&A section for all our experts to answer at the end of the webinar. Now, I'd like to invite the Program Director of the White Ribbon Alliance in Sierra Leone, Amy Koroma. Amy Koroma today will be discussing her knowledge and her insights into exploring experiences with smartphone AI in fetal ultrasound, a study from Tonkilili, Sierra Leone. Welcome, Amy.
Thank you very much, Katia. Hello, everyone. I am Amy Lumpui Koroma. I work in maternal and child health care And over the years, I have worked with various health stakeholders to understand the health needs of women and children in order to better plan for those needs. I recently studied at Royal Tropical Institute, where I met Enya, and I came to know about the baby checker. I became interested in baby checker and decided to base my thesis study on it. Next slide, please. Next slide. Yeah. Do you know that in Sierra Leone, most healthcare workers would go through their medical training and have their entire career working in maternity without ever seeing an ultrasound scan, yet alone know how to use one? The same is true for most pregnant women. Most women in Sierra Leone have to go through multiple pregnancies and never have the opportunity to have not one pregnancy scanned. And this is sad because this is the reality of most healthcare workers and women in Sierra Leone. And there is definitely a need for innovative, cost-effective solutions in order to reduce these high mortality rates in Sierra Leone. Enya already mentioned the effectiveness of ultrasound and baby checker to be specific, and we know how it can identify risky pregnancies in order to reduce the maternal and child health outcomes. So the question is, will baby checker be one of those innovative solutions for Sierra Leone? Because we know its effectiveness, we know it works. But when you look at the Sierra Leone context, will baby checker work as effective as it is meant to be? Next slide, please. So a little bit of background of the pilots in Sierra Leone. So the baby checker was piloted in Sierra Leone, Tonkolili district since 2022, and it was integrated in routine antenatal care visits where free scans were provided to pregnant women. And based on the results of the baby checker, the pregnant women were either managed at the primary health care or referred to a secondary care for further care. So my study objectives was to explore the adoption and sustainability of AI fetal ultrasound scan, or specifically baby checker in Sierra Leone. And mainly we want to look at the knowledge and awareness around ultrasounds in general, but also looking at what are the barriers and influencers to implementing not just baby checker, but related AI-related devices in Sierra Leone. I spoke with healthcare workers and clients as participants, and I actually went to Tonkolili district and collected the data myself through key informant interviews with the senior staff from the Ministry of Health and Sanitation and also from the hospitals. I also spoke with the frontline workers who were using the devices themselves. And of course, I also met with clients, that is pregnant women and lactating mothers who underwent the scans in these facilities. As part of my study, I used the NAS framework to actually put up the objectives and also to analyze some of the data. Next slide, please. So what do we find out? So as part of the description of participants, I find out that most of the healthcare workers in Sierra Leone are women. So 90% of the health workforce is dominated by women, but unfortunately, these women are in the lower cadre, and also most of them have low background, educational background. Next slide, please. So these are the key findings. So when it comes to the knowledge and awareness of the baby checker, all of the participants interviewed mentioned that indeed the device identifies risky pregnancies. And when it comes specifically to the clients, we're able to say that when we go to the healthcare facility, most of the healthcare workers will scan us and they will tell us whether or not our babies inside our belly are doing well or not. So you can see that they are aware of the baby checker's importance and they have to have their pregnancy scanned. When we look at the technology, the device itself being used, the user interface by healthcare workers, most of the healthcare workers, in fact, all of them said that the device was easy to use, mainly because of the visual guidance. The video indexed in the baby checker helped them to actually go through the pregnancy scan step by step, and they were able to self-train. One of the key aspects they also highlight about the baby checker was the traffic light system that is inbuilt in it that aids prompt referral. For instance, the baby checker will tell them whether or not they have to refer a pregnant woman or not. So as you can see, one of the healthcare workers mentioned that we realize that the scan helps us to reduce, for example, time spent on listening for a fetal heartbeat and determining the gestational period, which is difficult to do manually. We all know that human beings, we are great at doing things, but most times also we are not perfect. So, but with the technology, with the aid of the baby checker, they were able to actually identify some of these things. Next slide, please. So when it comes to perceived value, all of the healthcare workers and the clients mentioned that there is every need for the baby checker to be in their community, because for once, the pregnant women are coming for scans and they are strengthening other ANC services. So it increases ANC attendance. So women really appreciate the scans because it's proving to be effective. Also, it offers high diagnostic accuracy. So for instance, one of the pregnant women has to say, we even trust the device more than the healthcare workers because the errors are limited. So another client mentioned that many women have died or experienced stillbirth without knowing it before the baby checker gets to their communities and facilities. So indeed, they perceived it as having a high value. When it comes to adopters, they also mentioned because of the user-friendliness of the device, it was easy for them to adopt it within their routine work. So one thing I also find out is that technology is easy for healthcare workers to adapt if it can be easily integrated in their work. If it's a high burden, if it requires them to have on new documentation or new work to be done, it's difficult for them to have it adopted. So they said because of the user friendliness of the device with clear instructions, it was easy for them to actually implement this device in their facilities. They also mentioned as part of adopting that the challenges, including limited resources, for instance, they need examination bed so that they can use it to scan women. But in most of these healthcare facilities, you can only find one bed. Usually it's an admission bed that they will use to scan women. So they're struggling with this. So they mentioned that even though the baby checker device is good, it's working effectively for them, they need other facilities in their healthcare so that they can perform well overall. Next slide, please. So when it comes to organizational system, we see clearly the role of health system. So the weak health system in Sierra Leone comes out clearly because if you can identify a pregnant woman of having a particular issue, then you need to refer that woman to a secondary facility or tertiary facility. You then need something like an ambulance, or you need maybe medical drugs facility at the facility, but most of these things are not available. As you can see from a key informant that the reliability in Sierra Leone for proper procurement and restocking of accessories is the key problem. So this means that the weak healthcare system in Sierra Leone has an impact on any technology device being implemented. When you look at the wider system factors, we talk about policy and infrastructure gaps. So Sierra Leone does not have any policy that talks about high devices, technology-based devices or imaging devices can be used and implemented in the country. And also we are looking about infrastructures in terms of electricity, internet facilities. So as you can see, most of the healthcare workers did not mention internet or electricity as a problem. Not because it's not an actual problem, but because most of these facilities we are provided electricity or solar powers by partners, so it was easy for them. But if you look at the rest of the country, electricity is a problem, access to internet as well as data is also a problem. So the issue of corruption also came out clearly because as stated by one participant, saying that payment is also discriminatory. Some women are asked to pay while some don't pay anything for the same services. If you don't pay this money, you will not be scanned. They will tell you that the device is not available or not charged, and they will refer us to YILE, meaning the secondary referral hospital, even when we don't need to be referred. So as you can see, most of these issues affects the effective implementation of the device. And also generally the poor background, the general socioeconomic barriers hinder women from also coming to the facilities, mainly because if they come and if the healthcare workers tell them that this is the diagnosis, but then if we don't have drugs in place, if we don't have referral structures in place, then it's difficult for them to come again. Next slide, please. So when we talk about embedding over time, we're talking about sustainability, and generally we're talking about in Sierra Leone, there is very low digital literacy, and there are funding challenges that limit this. So as one of the participants mentioned, is that allocating the budget is okay, but then yearly subscription fee adds to the sustainability concern. This was discussed by a senior member of the ministry, saying that the device works effectively. I've seen it, and we'll be able to lobby with the local government to pay for some of the devices. But then when you consider the yearly subscription of the baby checker device, then that's where the real sustainable concerns arise. So outside of the nurse domain, another key area that emerged was quality of care. So what I observed mainly is that the shortened ANC time, but issues with privacy and counseling during scans. So women do not spend more time at the health facilities, mainly because the healthcare workers now have this diagnosis tool to help them with their diagnosis. But then we find out that they lack time to counsel pregnant women, and they also do not give them the proper privacy, the proper education they need before they are scanned. And also if they are scanned, most times they do not give them the results of the scan, except when they need to be referred, and they will just tell them that you need to go to the referral hospital for further care, and that's it. But one key thing that came out was the high community acceptance. Women love the baby checker. They love to be scanned. They are coming all the time, and they're coming earlier, which is very good, because then they can also be assessed for other ANC issues. So there are no sociocultural issues and high community acceptance. Next slide, please. So in conclusion, the baby checker is effective in the area that is actually enhances risk identification and ANC attendance, which is what we needed at especially the first trimester stage. It also facilitates task shifting, because all the healthcare workers were able to actually implement and use baby checker effectively, but then we need to look at the gaps in terms of holistic care. Also, I mentioned that there is need for clear guidelines and consistent supplies to ensure quality integration. And over-reliance on the technology risks diminishing manual care skill. Because one thing I also mentioned, one of the participants mentioned that we are using the baby checker effectively now that we are losing our skills, and they are failing to understand the complementary of the device instead of taking over their routine rules. Next slide, please. So finally, what are the implications for implementation? So we need to ensure that we educate healthcare workers that technology is there to complement their existing knowledge and capacity, and not to overtake the routine maternal and child health care.
سو ہمیں اس چیز کو یقینی بنانے کی ضرورت ہے کہ ہم ہیلتھ کیئر ورکرز کو ایجوکیٹ کریں ٹیکنالوجی کے بارے میں، اور ان کے نالج کو کمپلیمنٹ کریں اور ان کی کیپیسٹی کو بلڈ کریں. ایسی روٹینز کو بنائیں جو کہ میٹرنل اور چلڈرن کے کیئر میں سکلز اور سروسز کو زیادہ سے زیادہ بہتر بنا سکیں، اور ان کو ڈیجیٹل ڈیوائڈز دینا، ان کے لیے انفراسٹرکچرل ایشوز کو بہتر بنانا اور الیکٹریسٹی کو بہتر بنانا زیادہ ضروری ہے. In the Sierra Leone,
upload and download scans sometimes. So that's it. Thank you very much.
Thank you so much, Ami. Yeah, your study has been really insightful for all of us here at Delft and for our audience as well. Last but not the least, I'd like to invite my colleague, Julio Lopez, as
اب
Delft
آخری
head of
میں
ultrasound. He will dive deep into the heart of baby
میں
checker,
انوائٹ کروں
which is
گی
the
اپنی
AI.
کولیگ جولیو
The floor
لوپس
is all
کو
yours,
جو کہ
Julio.
ڈیلفٹ امیجنگ کے ہیڈ ہیں
Thank you very much,
الٹرا
Kate.
ساؤنڈ کے. چاچی آپ کا بہت شکریہ.
First of all, let's start that it is not only about having the best publication. It's more about bringing the artificial
سب
intelligence
سے
to the
پہلے
point,
شروع کرتے ہیں
like to really tackle the problems,
کہ یہ کوئی
bringing it
پبلیکیشن نہیں ہے,
offline and
یہ
making it
زیادہ
available in the phone.
آرٹیفیشیل
So
انٹیلیجنس
the
کو
people
دنیا
that
میں
actually need to use
اپنے
it can
پروسیجرز
use
میں
it
شامل
already.
کرنے کے لیے,
So I
پرابلم
had
کو
the
حل کرنے کے
opportunity
لیے بہتر سے بہتر ہے.
since I joined the company to travel around and see how the artificial intelligence is actually being used. And it's really nice to see here today some of the people that I met.
ہم
For
دیکھتے ہیں
example,
کہ
in that
آرٹیفیشیل
family,
انٹیلیجنس کو
I was
ٹیکنالوجی میں
able to
بہتر سے
see
بہتر
how they were
استعمال کیسے کیا
using
جا سکتے ہیں.
baby checker
جیسے
in
کہ ہم نے
health.
ٹافا انسومیا کو
I
دیکھا
was able to
کہ وہ اس
also
کو کس طرح
see during
استعمال کر
last
رہے ہیں
week,
بیبی
like
چیکر کو
Ethiopian
ہیلتھ کیئر
corona,
میں.
so I got to
میں
visit
بھی
Ile,
یہ
which
بھی
is a
دیکھنے میں
place where
قابل ہوا
people
کہ
currently are
پچھلے ہفتے
using
جیسے
baby
سیرالون
checker
میں
and
ہم
understand
نے دیکھا
how the
وزٹ کے
artificial
دوران ہم نے
intelligence it
دیکھا
use
کہ
not
انہوں
only the
نے
artificial intelligence but also the
بیبی چیکر کو
overarching
استعمال کرنے کے لیے ان کی
setting that we
پالیسیز
have
کیا ہیں,
called
انہوں نے
the phone
آرٹیفیشل
protocol,
انٹیلیجنس کو
transporting the
بیبی
phone
چیکر
from
کے
the
استعمال میں
they were
شامل
transporting the
کرتے ہوئے
case,
اس میں
understanding
پھر
the
اس
setting.
خاص کیس
And
کے
that's
بارے میں
something
بات
really
کی
important
جو
that
کہ
I
وہ
think
سب سے
sometimes with
خاص
artificial
طور پہ اس کی
intelligence,
جانچ
when
ہونا
we
ضروری ہے.
use, we forget that behind the
خاص طور
data
پہ میں
there is
سمجھتا ہوں کہ
actual people, in
آرٹیفیشل
our case, implementing
انٹیلیجنس
that
کے
imaging.
بارے میں
And
اچھی
it's
ہم
really
بھول گئے
enlightening to be
کہ
able
ڈیٹا
to
کلیکٹ
see
کرنا
that and do
اور
better
لوگوں کو
artificial
میڈیکل
intelligence by understanding
امیجنگ میں
the real
اے آئی کے
problems and
استعمال کی
how to
وضاحت
tackle
کرنا.
them. So if we go to the next slide, currently, next one. Currently, baby checker is able to detect gestational age, fetal
اس
presentation,
وقت
placental location,
بیبی چیکر ہے جو
presentation,
کہ
and prognosis.
جیسٹنل
We have been
ایج اور
working into
بچے
that
کی
for a
پریزنٹیشن کے
very some
پلیسنٹا
time,
کس جگہ
and
پہ
we are
موجود ہے
happy to
اور
say
ایک سے
that
زیادہ
the most
پریگننسیز کو
personalization we are
جانچنے کے
able
لیے
to get, it's
کام
we
کر
have
رہا
a
ہے.
mean
ہم
absolute
اس پہ
error of 2 days. So that
ابھی
means
کام کر
that
رہے ہیں
we
کہ
are
ہم
6 days difference in average from an actual sonographer or obstetrician.
جیسٹیشنل
Fetal
ایج
presentation, it's
کو جانچنے کے لیے
accuracy
ہم
of 98%
بیبی
in the third trimester, which is when it can
6
actually
دن
be
کے
a risk, and the placenta location has an accuracy of 90% in the overall data. And
بیبی
the
چیکر
multiple
آج
pregnancies,
اس
which is the
وقت
latest
جی
thing
میں
that we have
پریگننسی
implemented,
90% ہے
we are still
اور
validating
ملٹیپل پریگننسیز
with the
ایک سے
team.
زیادہ پریگننسیز کا موجود ہونا بھی
Soon to be
بیبی چیکر میں
integrated
شامل ہے.
in the amniotic fluid volume, stillbirth,
اور
and
جلد
some
ہی
other
ہم
things that we
اس
are
قابل ہو جائیں
still
گے کہ
looking
ہم
to
ماں میں
research
ایمنیوٹک
on.
فلوئڈ کی
And that's
مقدار کو
where it's important
جانچنے
to
میں
find these
کہ وہ
collaborations
کتنا
and
ہے,
understanding and have these conversations
اور
with
اس
the
کے متعلق
doctors
کوئی
and the
اور
sonographers
کمپلیکیشن
to
ہے تو وہ
understand
جانچنے
which
کے
are
لیے قابل
the
ہو سکیں گے.
relevant things that need to be
ہم
researched, the things
ڈاکٹرز
that
اور
are actually
الٹرا
going
ساؤنڈ
to
کرنے
be
والے
used in the
سونوگرافر
settings
کو
where we
بھی
are,
یہ
and
بہت
which
جلد
things
اس
can
کے
actually
متعلقہ
be
تعلیم
what
دینے میں
can we do
کامیاب ہو
about them.
سکیں گے اور اس
So
تک رسائی دینے میں ہوں
really
گے.
important. Like if we continue to the next slide. At the moment, as I was saying, it's not
اس
about
وقت
having the
جیسے
best
میں پہلے
publication.
کہہ رہا
We
تھا
had our
کہ
first
یہ صرف
publication that's the first one exactly linked to
پبلیکیشن
the
نہیں ہے, یہ ہماری فرسٹ
maternal
پبلیکیشن تھی
neonatal
پہلے,
sector. It was in 2018. So if
جو
you
کہ ماں کی
click on the next screen,
صحت
you will see the
کے بارے
publications
میں تھی,
appearing.
اور جو کہ 2018 میں
So
تھی,
we have like the first publications actually happened like back in
اور ہماری
2018.
پہلی پبلیکیشن
And
جو
that brings us
2018
really
میں
into
ہوئی
bringing
تھی.
it offline and trying to understand which the settings were. Like from that point, we started doing more publications.
یہ وہ
And here in
نقطہ
my
تھا
next
جہاں سے
slide
ہم نے
is the
پبلیکیشن کو
first
شامل
one where we
کرنا
were
شروع
able to
کیا, اور اس
present
کے
in the
بعد پھر ہم
MIDI conference,
اس کو جاری رکھنے
which
میں
is a really
کامیاب ہوئے.
important medical imaging conference for artificial intelligence,
جیسا
where
کہ ہم نے اس
actually
کو
it was Brad
میکائی
presenting in
کانفرنس میں,
collaboration with us.
جہاں پہ
And it was
امپورٹنٹ میڈیکل
presented as
امیجنگ
the most
کانفرنس میں
practical
ہم نے
application of
آرٹیفیشل
artificial
انٹیلیجنس کو
intelligence
اس میں
and
شامل
the
کیا.
most relevant and clinically
روڈویل
effective
پریزنٹیشن
workshop
کولیبریشن
that
میں
was happening. So in this case, what we did, it was for detecting
اس کیس میں ہم نے
fetal growth
کیا کیا ہے
manifestations
کہ ہم
using
نے
abdominal fluid culture.
بچے کی گروتھ کو ڈیٹیکٹ کرنے کی میں جو چیز رکاوٹ تھی اس کو جانچنے میں مدد حاصل کی. ابھی بیبی چیکر کے پلیٹ فارم میں ہم کیا کچھ اس سارا ویبینار ہم نے ایک ویبینار کنڈکٹ کیا کہ کیا اندر ماں کے پیٹ کے اندر ہو کیا رہا ہے اور اس کو ہم حل کیسے کر سکتے ہیں. اس میں ہم نے آرٹیفیشل انٹیلیجنس کو بیبی چیکر میں شامل کیا جو کہ پچھلے سال ہم نے ایک ریسرچ سے انڈرسٹینڈنگ حاصل کی. ہم نے اس انڈرسٹینڈنگ سے ہمیں یہ معلومات حاصل ہوئی کہ یہ استعمال کیا جا سکتا ہے اور سمجھا جا سکتا ہے ایسی سیٹنگز میں بھی جہاں پہ یہ سمجھا جا سکتا ہے, جو کہ ایسے ممالک ہیں جہاں پہ کم یا درمیانی انکم والے ممالک ہیں, جہاں پہ انٹرنیٹ کی ایکسیس بہت کم ہے, جہاں پہ بجلی بہت کم ہے. وہاں پہ ایسا بیبی چیکر کرنٹلی ہم نے دیا جائے جو کہ فون سے چارج ہوتا ہے اور اس میں فون کے ذریعے ہی اس کی فون کی بیٹری یوز کرتا ہے, اس کے لیے کوئی ایکسٹرا الیکٹرک پاور کی ضرورت نہیں ہے. یہ سارا کچھ ایک فون میں ہے اور یہ خود بخود ہونے والے آسانی سے استعمال کیے جانے والا بیبی چیکر ہے. یہ بھی گانا میں, زیمبیا میں, ٹافا میں لوگ اس کو استعمال کر رہے ہیں اور یہ ایک ایسی چیز ہے جس کو ہم نے ممکن بنایا اپنے پارٹنرز کی مدد سے, ان سب لوگوں کی مدد سے جو ہمارے ٹرسٹ میں شامل پچھلے سال سے شامل ہوئے. یہ ایسی چیز ہے جس پہ میں نے بہت سارے سوال پوچھے, اس بارے میں بات ہو رہی تھی جی. ہم نے بہت سارا ڈیٹا اکٹھا کیا کہ بیبی چیکر کو آسانی سے کیسے استعمال کیا جا سکتا ہے, کتنے اسکین کیے جا سکتے ہیں اور یہ رسکی ہو سکتے ہیں یا نہیں ہو سکتے, کینسر کو ڈیٹیکٹ کر سکتا ہے کہ نہیں, اس کی ایوریج پرفارمنس کیا ہے وغیرہ وغیرہ. بیبی چیکر میں یہ ساری چیزیں ہم نے شامل کی کہ یہ کتنے
it's already having the last touches to finish it. And this will allow to establish and improve the organization systems for gathering, analyzing, and reporting key health indicators. It will reinforce underlying health structures using Baby Checker, and it will allow also to have more evidence-based decision-making in the product. This is something that we currently are able, like imagine in Chile, which is a rural
یہ ایک ایسی چیز ہے جب ہم کرنٹلی ہم اس قابل ہوئے کہ اپنے رورل ایریا سری لونا کے دیہاتی علاقوں میں اس کو شامل کیا جا سکے اور اس کو ڈیجیٹل ڈیٹا کے ذریعے چلایا جا سکے, جیسا کہ ایسا پلیٹ فارم جو ہم بلڈ کرنا چاہ رہے ہیں کہ ایسے ایک پلیٹ فارم سے دوسرے پلیٹ فارم تک پبلک ہیلتھ پلیٹ فارم پہ سری لون میں اس کو پاس کیا جا سکے.
In places and digitalization in places where it's really complicated. So currently this will be available during the next quarter. So like it will be available.
تو یہ اگلے کوارٹر میں اویلیبل ہوگا, جیسے کہ اگلے سال فیبروری تک, جو کہ ایسی چیز ہوگی جو پہلے سے بہت بہتر ہوگی, جو بہت زیادہ ویلیویبل ہوگی, قابل استعمال ہوگی, جس سے جو کہ ہمیں بہتر طریقے سے ایک تصویر دے گی, جس سے ہم آرٹیفیشل انٹیلیجنس کا بہتر سے بہتر استعمال ریزلٹس ملیں گے.
From the artificial intelligence and the product is that we have been working really hard to not only
وہ میرے لیے کہ آرٹیفیشل انٹیلیجنس کو استعمال کرتے ہوئے بہتر سے بہتر نتائج حاصل کرنے میں ہم بہت محنت کر رہے ہیں, جو کہ بہت زیادہ اہمیت کے حامل ہیں کہ اس چیز کو ایک ایسی پروڈکٹ بنایا جا سکے جو کہ ہیلتھ ورکرز کو ایسی جگہوں پہ جہاں پہ اس کی بہت زیادہ ضرورت ہے وہاں پہ ان تک رسائی حاصل کرے, جیسا کہ کمیونٹی سینٹرز ہیں جہاں پہ ان ٹولز کا ہونا بہت ضروری ہے. اور ہم بہت خوشی ہوگی کہ ہم دیکھیں کہ زیادہ سے زیادہ لوگوں تک اس کی رسائی حاصل ہو سکے اور بہت سارے نیو ریسرچرز اس چیز میں نئے فیچر شامل کر سکیں. میں ایک دفعہ پھر اپنے سارے پارٹنرز کا شکریہ ادا کرنا چاہوں گا. میں امید کرتا ہوں کہ کوئی اور ایسی کوئی اور گہری سکھلائی اس چیز میں شامل کر سکیں گے جس سے ہم مزید بہتر جدت کی طرف جا سکیں. آپ سب کا بہت شکریہ.
Thank you so much, Julio. This was really insightful and really fascinating to see where Baby Checker can go and how. I'm sure all of our audience is very curious and full of questions, much like me. So now I would like
آپ
to
سب کا بہت
invite my
شکریہ. مجھے
colleague
یقین
Florence,
ہے کہ
who
ابھی
will be tackling all
ہمارے
of those in the Q&A
سوالات
session.
کے جوابات سننے میں لوگ بہت زیادہ
Yes, thank you.
پرجوش ہوں گے.
Kaatia, and thanks for everybody for joining, of course, today.
آپ
We
سب
had
کا
quite a number
جوائن
of
کرنے کا بہت
questions, but
شکریہ.
we're going a bit
ہمارے
over
پاس
time
کافی
this
سارے
because then it leaves more room
سوالات ہیں.
to
ہم
also for
پہلے ہی
speakers.
زیادہ
What
ٹائم
I'm
لے
going to do is
چکے
read
ہیں.
out a couple of questions that I think would
ہم
be, I
دیکھتے ہیں
thought,
کہ
quite
ایک دو
interesting
سوال
and
لے
would be
لیتے
good to
ہیں
answer
جن
as
کا ہم
live.
بہتر سے جواب دیا
And
جا
all of the
سکے.
questions have been answered for people also in the chat. And be
چیٹ
assured
میں
that
کچھ
we'll give
سوالات
you
کے
those
جواب دیے جا
answers
چکے ہیں.
after the call, so everybody will receive that. So firstly, I wanted to touch upon a question raised by Marlene, who says that great to have technology incorporated in pregnancy care and to pilot projects and do case studies that result in great reports. The
سب سے
challenge
پہلا
with
سوال ہم
integration in
لیتے
health
ہیں کہ
systems
جو کہ
is there any
مارلین نے
evidence of
کیا
survival of the
کہ
project after the end of the
ٹیکنالوجی
pilot
کی
project.
شمولیت
Well,
پریگننسی
Enya, you
کیئر
can
میں کس
comment on
طرح
that a little bit. I saw you already
زیادہ سے
responded to
زیادہ
this, but
فروٹفل
perhaps
ہو
also I.
سکتی ہیں.
Yes, we saw a few questions like that, which is of course really important. It's really important that Baby Checker
بہت
exists
کم ایسے سوال
beyond
ہوتے ہیں جو
the
بہت زیادہ
actual baby
اہمیت
checker
ہوتے
Hear
ہیں,
us,
تو
so
یہ
Enya?
اہمیت ہے.
in the app.
Can't hear or see you.
Can you hear me?
Yes.
Fortunately, it be an
Yes, I
audio
can hear you.
error, but let me then just bring up also the answer here, and perhaps we get it up and running in parallel, but then I also read it. So it was also mentioned in the Q&A, and you mentioned the objective is definitely for Baby Checker to be integrated as an ANC tool, and therefore also in health systems used locally. Currently, not many of the partners and clients that we have such digitized health systems, unfortunately. So we provide a dashboard where stakeholders can access data about the Baby Checker scan, such as the quantity, quality, results, and rates of total attendance, attendance per pregnancy, and attendance per trimester. And I think Julio also touched upon this. When partners have digitized health systems for Baby Checker to integrate to, we'll be more than glad to collaborate to make ANC and data more holistic. Delft Imaging has a lot of experience in integrations, for example, with TB being integrated in the Kenyan surveillance system of TB. And I think you're already up and running again. I don't know if there's anything else you wanted to add to that.
Can you hear me?
Hey, Enya,
Yes.
we can hear you. Please go ahead.
Okay, perfect. Yeah, well, Florence, you covered all the bases basically, and yeah, I was glad to type all the responses in the Q&A. I think we got a few questions about that. It's really important for us that what we're building exists beyond just the Baby Checker.
ہاں, کوشچن آنسر سیشن میں جو سوالات ڈالے گئے تھے ان کے زیادہ سب کے جوابات وہاں پہ لکھ کے ڈال دیے گئے ہیں. یہ ایک سوال ہے کہ بیبی چیکر ایپ کنٹریبیوٹ کر رہی ہے ڈیجیٹلی اینٹینیٹل کے ڈیٹا کو اکٹھا کرنے میں جو کہ اویلیبل ہے اسٹیک ہولڈرز کنٹریز میں. یہ بہت زیادہ ممالک نہیں ہیں, بہت سارے پارٹنرز جو ہیں وہ ہمارے ساتھ کام کر کے فنکشنل ہو چکے ہیں. ڈیجیٹلائز ہیلتھ سسٹم کو اور منیجنگ سسٹم کو اس طریقے سے ہم بلڈ کر سکتے ہیں کہ ایسا ڈیش بورڈ جس سے اس کے رسپانس کے بارے میں معلومات ساری مل سکتی ہیں, ایسا ڈیش بورڈ جس سے اس کو استعمال کرنے میں اور اس کا ڈیٹا حاصل کرنے میں بیبی چیکر کا مدد حاصل ہو سکتی ہے.
Great, thank you for that. And I think another interesting
بہت
question
شکریہ.
that was raised was from Heidi in
ایک
touching
اور
upon how
انٹرسٹنگ
ICs
سوال ہے جو
scale
کہ
up
دیا گیا ہے LMC funds and scale up میں.
This is something you touched upon. Perhaps you can go first, and I see Dr. Ganda also responded to it. I don't know, perhaps you want to go first, Enya, and then after you, then Dr. Ganda can maybe touch upon it further.
Yes, sure. This was Heidi's.
Exactly, yeah, Heidi's question.
Yes. So far we don't have any projects that have scaled up to counties.
تو ابھی تک ہمارے پاس کوئی ایسا پروجیکٹ نہیں ہے جو کہ ان ایسے ملکوں میں یا ایسے اضلاع میں پورے ملک میں پہنچ سکے کہ ابھی ہمارا بیبی چیکر کو اس کے جو شروعات کی جگہ ہیں اس سے اگلے فیز میں لے کے جانا ہمارے لیے شروع نہیں ہوا. ابھی ہم مزید نان NGO سے اور مزید ڈونرز سے رابطہ کر رہے ہیں کہ وہ فنڈ اس کو پرچیز کریں بیبی چیکرز کو اور فنڈ جنریٹ کر کے تو اپنے ٹارگٹ کنٹریز تک اور کم وسائل والے ممالک تک اس کو پہنچایا جا سکے. ڈاکٹر گانا ہم سننا چاہیں گے آپ کی کیا ٹیک ہے اس بات پہ. میرا خیال ہے یہ ایک اچھا سوال ہے جو پوچھا گیا ہے. اس کی اسکیلنگ ڈپینڈ کرتی ہے کہ آپ کے فنڈنگ کے طریقہ کار کتنے ہیں. جیسا کہ اگر آپ کے فنڈ جو ہیں وہ پرائمری ہیلتھ کیئر تک ہیں کینیا میں جیسا کہ تو ہم نے اس میں بتایا کہ اس کی کچھ ایسے ماڈیولز ہوں گے جہاں پہ فنڈنگ کے ذریعے ہی اس کو زیادہ اپلایا جا سکتا ہے. اگر فنڈنگ زیادہ اکٹھی ہوگی جس کے لیے خاص پیسوں کی خاص مقدار ہیلتھ کیئر کے لیے ڈپیوٹ کی جاتی ہے تو ہم جیسا کہ ہمیں چاہیے کہ کم از کم 2 الٹرا ساؤنڈ کریں ایک عورت کے پریگنینسی میں.
Because otherwise the mother would still have to pay for it if she does it somewhere else. So those are the kind of funding models that we are looking into for Kenya.
تو ہم اس طرح کے ماڈیولز کو دیکھ رہے ہیں جو کہ جس سے اس میں ہمیں مدد مل سکے. تھینک یو. آپ کا بہت شکریہ.
I think that's also one of the things that I maybe also wanted to comment on from Delft side that
آپ کا بہت شکریہ جواب دینے کا. میرا خیال ہے کہ یہ ایک بہت اچھا کمنٹ تھا جو بھی ڈیلفٹ سائٹ سے دیا جائے گا. جیسے کہ میں نے پہلے کیا ہے کہ میری اپنی پریزنٹیشن میں آرگنائزیشن کے طور پہ ہم نے یہ کوشش کی ہے کہ ہیلتھ پرابلمس کو ہم کس طرح ٹیکل کر سکتے ہیں ٹیکنالوجی کے ذریعے. اور یہ ایک پارٹنرز کے ساتھ مل کے جدت کی طرف جانے کا ماڈیولز ہے جس سے ہمیں یہ طریقے نکالنے چاہیے کہ فائنینس کون کرے گا, فائنینسنگ کتنی ہو سکتی ہے. آپ سب کو کوشچن آنسر کی شیٹ مل سکتی ہے اور آپ کو ریکارڈنگ مل سکتی ہے اس کی. کوشچن آنسر شیٹ میں سوالات کے جواب مل سکتے ہیں. آپ ہم تک بعد میں کبھی بھی رسائی حاصل کر سکتے ہیں اگر آپ کے سوال ہیں. میں آپ سب کے جوائن کرنے پہ آپ کا بہت شکر گزار ہوں کہ آپ سب اکٹھے ہوئے اور آپ نے ہمیں جوائن کیا. امید کرتے ہیں کہ ہر کسی کے لیے ویبینار بہت زیادہ یوزفل رہا ہوگا. میں اس ویبینار کو ابھی اختتام کی طرف لے کے جاتا ہوں. ہم کنٹینیو کرتے ہیں. آپ سب کا بہت شکریہ. تھینک یو ایوری ون.